Right, good afternoon everybody. Hope you've all had a nice little lunch. And everybody's not going to fall asleep now. We'll try and keep it interesting for you. So I'm just going to give you a brief whiz through cervical lymph nodes. For those that are interested, this is from Fury Road. If you've not seen Mad Max Fury Road, this is from this picture's taken from there because somebody's just asked me. I just assumed everybody had seen it, so that's how it is. So we're going to talk a little bit about lymph nodes now, and then some of my colleagues go on to talk about salivary glands, and then we'll have a bit more practical at the end of the afternoon, and then there's another good quiz coming just to finish it all off, where we can see how much you've paid attention all day. So yeah, so if you can have the next slide, please. So yeah, so lymph nodes is all about the context of the lymph node, isn't it? You know, it's the patient that we see who's got the neck lump. It's all about that kind of, what context do we see in that neck lump in? What is that risk assessment that we do? So we eyeball the patient, don't we? Some patients come in the door a bit like the picture I put up before, and you think, oh yeah, you've got something. You know, you pass that walk in the door test. I've got a second head. But it is important to contextualise, and often when we take a history and see a patient, we're already in a space where we're thinking, this is a high-risk patient, this is something we can see, or actually this sounds a bit, yeah, it doesn't sound like there's much of anything wrong. You know, you've got a young patient, bit of up and down lymphadenopathy, that sort of thing. So you just got to contextualise what we're doing. And I think it's easier for those of us that are, you know, clinical sort of head and neck ENT based, because we get that privilege when we see these patients, but our radiology and ultrasonography colleagues sometimes don't get that privilege. They get it from what we put on the request card, if they're lucky. I can see somebody raising his eyebrows at me at the front row. But actually, in our heads, by the time we've seen and examined a patient, we've often already got to a diagnosis, sometimes before we've even seen the ultrasound, whereas it's a little bit different looking at it from the other side. So depending on where and when you see these patients will depend on what happens. Obviously, we're interested in any other symptoms. Some patients will come with a whole plethora of symptoms. Some patients will come and just say, actually, no, I've just got a lump. It's all about, you know, thinking about the patient as a whole, smoking, alcohol, HPV, other risk factors for head and neck cancer. Do they have any systemic symptoms that might point to a more systemic cause for their lymphadenopathy? And how old are they? And sometimes, and I think Vino will show you he's going to show you some images, but essentially sometimes something in a young person's neck might look the same as something in an older person's neck, but might be two very different things. Things like branchial cysts I'm talking about now are. So branchial cysts, you're allowed to have a branchial cyst, aren't you, if you're under 35? You're not allowed to have a branchial cyst if you're 60 anymore. And that's how it goes. So if we talk about the value of ultrasound, ultrasound in neck lumps is a really valuable tool. And actually, if you look at its sensitivity and specificity compared to things like MR and CT, ultrasound with FNA is actually the best we can do for our neck lumps in a good operator's hands. And so it is really particularly the core of investigation for our neck lumps, and that's why it's so important that, you know, we all have either open access to it or we've got an idea of what we're doing with it. It'll allow us to assess lymph node status and sometimes primary tumours. You know, Michael's shown you very nicely this morning, you can see the intrinsic tongue muscles, you know, and sometimes you can FNA primary tongue tumours through the neck if you've got a big tongue tumour, because if the patient's got trismus and you've got no access, it can be a useful adjunct to actually get a diagnosis of a primary site. We saw one in MDT just the other week where very deep base of tongue tumour coming forward, but actually accessible through the neck rather than through the mouth. It can, as we've already discussed, be difficult to see beyond the mandible sometimes, and other deepest neck spaces, things like parapharyngeal space, can also be quite difficult, as can the deep lobe of the parotid. But it can be very accurate, and it's very good at differentiating malignant lesions from benign lesions. And if you add in FNAC of anything that looks vaguely dodgy, actually, we can get this right most of the time, okay? So we've talked about using true cuts and cores, and the end naught neck, which is really important when you're treating squame. If you've got an end naught net and you ultrasound them and it's an end naught net, it's highly likely to be an end naught neck. Ultrasound's very specific for that sort of thing. So it is really useful for us. But these are all the things you might find as well. This is not an exhaustive list. Other lists are available, okay? But essentially, there is lots of things you can find in the lateral neck. And although, you know, common things are common, and a lot of what we see, a lot of the neck lumps we see don't turn out to be cancer and turn out to be reactive lymphadenopathy. This is a really easy, non-invasive way, even without FNAC, of actually telling a lot of patients that we see, you're okay, you can go away, you don't need us to worry about you, okay? But you can pick up lots of other things, you know, and you can make lots of other weird and wonderful diagnoses. You know, we can find things like HIV, you know, you see multiple parotid cystic lesions, you know, you get that's pretty unique to HIV. We get lots of other infections, particularly in central Manchester, because we like weird and wonderful infections. We've had syphilis, we get lots of TB, that sort of thing. We get lots of connective tissue disorders. You can get congenital malformations, lipomas, abscesses. The list is, as I said, not inexhaustive. And, you know, we've got a really big haematology department. We get all sorts of weird and wonderful stuff from them. So, you know, that's the sort of thing that you're looking for. Press it again. We've been through this. Be consistent, okay? It's important that we are consistent when we talk about net levels and we talk about where lumps and bumps are. And again, for those of us that deal with head and neck cancer all the time clinically, where your lymph node is tells you where your primary is a lot of the time. So it's really important that we get that consistency and knowing what those levels of the neck are. And this is just a little illustration of the lots of different lumps and bumps. But again, the age of the patient, the context of the patient and the site of the lump will give you a pretty good clue most of the time as to what you should be thinking that you're already there. And you will be right most of the time. So, things we want to know, and Vina will probably cover some images to do with a lot of this, but these are the sorts of questions you should be asking yourself when you're scanning people's necks and you think you've got a lymph node. Not all of it will be lymph node, but you think you've got a lymph node. So is it reactive or not? Can I leave it alone? Do I need to be worried about it? Does size matter? Okay. All right, we've talked about size a little bit in thyroid this morning. We've talked about thyroids. Actually, does size trump what it looks like inside or not? Or is it more about what it looks like inside? So again, we'll get some more examples of that. Shape, ovoid versus round. So we talk about round nodes. We don't like round nodes, do we? Talk about echogenicity. Do they have a hilum or not? When you put the colour probe on, do you see that nice little vascular hilum, or is it just an empty space? Is it necrotic? Is it a cyst? Is it calcified? If you're not sure about it and it's not definitely reactive, FNA. If it's suspicious, FNA, do you do a true cut? Do you organise cross-sectional imaging at the same time? If you think you've got something that's definitely suspicious, then often we would do that in synchronicity, because if we're already thinking this patient's got a malignancy, we're going to want some more information about where it's come from and where else it's gone. Can you see extracapsular spread? Okay, if we're talking about potentially surgical versus non-surgical treatment for head and neck cancer, extranodal extension is a really important delineator of whether we offer surgery and whether patients end up with dual or even triple modality treatment sometimes. So that's really important for us. Is it just one or are there lots of them? And any other characteristics we might be interested in. And what's it stuck to? And where is it? Okay, because there's a big difference between a nice little lymph node in the posterior triangle for a biopsy to something that's sitting on top of the thoracic duct. And yes, you can give people Kyle leaks just doing lymph node biopsies. I've done it. Okay, so, you know, it's important to know what the relationships of these are. And that's about all I've got to say to you. So Vina's going to take you through some pictorial representation now of what I have just talked about to try and illustrate it a bit more. Okay, thanks, Vina.